Hi, thank you very much for the opportunity to talk today. I'm going to be talking on tips and tricks for echo assessment of athletes. My name is David Owens. I'm an associate professor at the University of Washington in Seattle. And I have the dual role of running our hypertrophic cardiomyopathy and cardiovascular genetics program, but also um, helping out with our Center for Sports Cardiology. I don't have any disclosures. So the first half of this talk is going to be talking a little bit of an overview about sports cardiology, and then we're going to get into more broadly, or more specifically, having to do with echo assessment of athletes. And I think to understand the exercise-induced cardiac remodeling process is essential for us to be able to properly interpret the echocardiograms that we see in these athletes. So sports cardiology as a field has been emerging, in large part because the number of individuals engaging in higher level exercise and activity has been increasing over the past several decades. This includes professional and intercollegiate sports, but also intense recreational activities such as marathons and triathlon, and also masters events, so people who are exercising to a high capacity into their senior years. The sports cardiology has really emerged as a field to respond to the unique challenges and desires in this patient population. So when we think about sports cardiology, there's really three main components to this. The first is the evaluation of the symptomatic athlete. There's management of athletes with cardiovascular disease and prevention and screening for sudden cardiac death. To do each of these appropriately, they all require an understanding of exercise-induced cardiac remodeling and how to differentiate it from pathology, and we'll be going over this over the next several slides. But first, let's try to get a mutual understanding of what exactly is an athlete. This is the definition that's been taken from the Bethesda Conference guideline, and it's generally accepted as a reasonable definition of an athlete. And that is one who participates in an organized team or individual sport that requires competition against others as a central component, places a high premium on excellence and achievement, and requires some form of systematic and usually intense exercise. One thing to know about athletes is they come in all different sizes, and so do their hearts. We have athletes who are over 7 feet tall. We have athletes who are more diminutive in stature, and we have a lot of recreational athletes who fall someplace in between. We also know from a lot of headlines that sudden cardiac death occurs in athletes, and it can be very tragic and high profile. Fortunately, these events are rare. The events tend to happen more in men than in women. This may be biologic. There could be some sociologic differences. In all cases, though, we think of it as exercise being a trigger in the setting of some underlying arrhythmogenic substrate. We'll talk about that in just a second. We also noticed, just from an observational standpoint, that burst activities such as soccer, football, basketball, where there's a lot of stopping and starting, tend to have more sudden cardiac arrest events than the sports where there's continuous exercise. And that may be having something to do with the heart rate variability that occurs in those sports. The substrates that are capable of causing sudden cardiac death include genetic conditions such as cardiomyopathies, channelopathies, and aortopathies, such as Marfan syndrome. They also include some congenital heart abnormalities. Perhaps chief on that list is the anomalous coronary artery. Parkinson-White has been speculated to cause sudden cardiac death, and then some association, minor association with congenital aortic stenosis. There's also some acquired conditions such as coronary disease, myocarditis, or commotio cordis, which is the sudden impact of a hard ball or puck onto the chest wall at just the right timing of the cardiac cycle. When you look at epidemiologically at the types of underlying conditions that cause sudden cardiac arrest, this is actually taken from Barry Marin's publication in 2015. And in his series of 1,300 young athletes, the most common cause was actually sudden unexplained death. This may be related to some underlying channelopathies that were not apparent on autopsy. But hypertrophic cardiomyopathy or unexplained left ventricular hypertrophy accounted for the vast majority of other cases. Anomalous coronary arteries was an important subset, and then a smattering of others, including myocarditis, ARVC, coronary disease, and the commotio cordis. We go about looking at echocardiograms for the purpose of screening for causes of sudden cardiac death. We'll keep in mind that these are the types of things that we'll be looking for. So I'm going to talk a little bit about the exercise-induced cardiac remodeling process, because I think a proper understanding of this is really essential to understanding echoes in this population. First off, let's talk a bit about the determinants of fitness. Aerobic fitness is really determined by the oxygen delivery system. And so oxygen gets absorbed by the lungs. It gets delivered by the circulatory system to the periphery, to the skeletal muscles, where it is taken up and then metabolized and turned into energy. The largest determinant of this fitness is oxygen delivery. And at rest, we have a cardiac output of 5 to 7 liters per minute. And when we start to exercise, that can increase 4 to 5 fold for untrained individuals, and perhaps even higher for individuals who are trained, such that some individuals can get their cardiac outputs up to 35 to 40 liters per minute at peak exercise. When we go from sedentary to exercising, the early gains are really due to improved oxygen uptake and metabolism. And it takes some time to really modulate this oxygen delivery system. But the later gains and the gains that are going to stick with us are largely due to this cardiac remodeling. And that's what allows the increased oxygen delivery that differentiates the elite athletes from the recreational athlete. The cardiac remodeling process can differ based on the type of exercise that you engage in. This is something called the Morgan-Roth hypothesis that says that if you do a lot of endurance exercise, you will get a volumetric load on the left ventricle, which will then result in left ventricular dilation. And if you do more weight-based or strength-based training, you get a more concentric type of remodeling process. Now, this is a nice sort of schematic to understand how the remodeling process might occur. But in reality, most individuals, most athletes engage in a combination of these types of activities. This is perhaps the best example of the cardiac remodeling process. And this is work by Ben Levine down at UT Southwestern, in which he took 12 sedentary subjects, ages 29, and had them go from sedentary to training for a marathon over the course of 1 year. There's a progressive intensity. The types of activity that they did were predominantly aerobic. And you can see on the 12 months of training on the x-axis here, and then training intensity on the y-axis, that there's a graduated level of increased intensity over the course of that year. The subjects underwent serial cardiopulmonary exercise testing and serial cardiac MRI imaging, and actually had a invasive hemodynamic monitoring at baseline and at the completion of the study. Over the course of the year, we see the changes that can occur both in left ventricular size, right ventricular size, and left ventricular wall thickness. Here on the left, you see the left ventricular end diastolic volume increases throughout the course of the year, perhaps increasing a little bit more as the exercise intensity increases. And then the right ventricle probably increases a little bit more early in the exercise training, but does also increase over the course of the year. And wall thickness tends to increase early and then kind of flatten out. Over the course of this year, we saw a 17% increase in LV size, a 27% increase in RV size, which was fairly proportionate to the increase in peak VO2, which was around 20%. The exercise-induced cardiac remodeling process has a number of different factors that influence it. Perhaps the most robust of this is the type of exercise that is performed, both the exercise intensity, the modality of exercise, but also exercise duration, and not just like exercise for 30 minutes a day, but how many years have you been doing? Have you been doing conditioning continuously? Is there any period of deconditioning along the way? Those types of things. And so when I evaluate an athlete and I'm trying to understand it in relationship to the echocardiogram that I am looking at, I will take an exercise exposure history and try to sum up the amount of exercise they've done over the course of their life. Other factors that influence the cardiac remodeling process include age, sex, race, ethnicity, and genetics. This is a couple of examples of two echocardiograms of athletes that we've taken care of at the University of Washington, both at a collegiate level and then at a professional level. This individual on the left was a cross-country runner, and you can see the left ventricular end diastolic volume index is significantly increased, even though when you look at it, this looks like a pretty normal echo. So if you didn't do the quantification, you'd think this is pretty normal, but in fact, he's got four-chamber enlargement. And then on the right here, this is an individual who isn't playing right now, who was a national champion level sprinter, who had more RV enlargement than LV enlargement, perhaps because he wasn't engaging in as much endurance exercise. When we look at elite athletes, we can see some of the extremes at which this process can occur. So we look at echocardiograms from Tour de France cyclists. This is an older study, but I think it's a valuable lesson here. And on the x-axis here, we're looking at left ventricular internal diameter in millimeters. And on the y-axis here is left ventricular ejection fraction. And so when we look at the norms at our echo lab, all the individuals in the red shaded area have a dilated left ventricle. And all of the individuals in the blue shaded area have low ejection fraction. And so if you look at the area of overlap between the two, you see a substantial number of these elite athletes have a dilated left ventricle with a low ejection fraction in a way that would very much mimic a dilated cardiomyopathy. What sets these individuals apart from somebody with a cardiomyopathic process is that their ability to exercise and augment that contractile function. When we look at wall thickness by race and sex, we see male athletes on the left and female athletes on the right, divided into white athletes and black athletes. We see that black athletes in general have 1 to 2 millimeter increase in left ventricular wall thickness compared to their white athlete counterparts, both in men and in women, and that men on average have a 1 to 2 millimeter, perhaps 2 to 3 millimeter increase in left ventricular wall thickness compared to women. This is true also in Asian athletes, and we see the distribution of left ventricular wall thickness over here, such that female athletes' maximum extreme of hypertrophy that is related to exercise appears to be about 11 millimeters in women and about 13 millimeters in men. If I go back to the other slide here, you'll see that in black athletes, the upper limits of physiologic hypertrophy is on the order of 14 to 15 millimeters, perhaps even up to 16 millimeters in some extreme circumstances. All of this leads to some gray zones in which we have this interesting conundrum of what is a healthy heart or an extremely one that's capable of extreme performance and one that is diseased. And so we have these gray zones between athlete heart and hypertrophic cardiomyopathy, between athlete's heart and dilated cardiomyopathy, between athlete's heart and left ventricular non-compaction, and between athlete's heart and arrhythmogenic right ventricular cardiomyopathy as well. There's also gray zones with Marfan syndrome and myocarditis. So these are the types of things that when we are looking at an athlete, we really need to try to rely not just on the size and function of the heart at rest, but try to dig a little bit deeper and try to understand that heart a little bit better. So when we're looking at assessing the left ventricular hypertrophy in athletes, one of the chief and most important things we can do is measure wall thickness correctly. There's this RV band that comes in, the RV crista interventricularis that comes in right at the basal septum that on the peristernal long axis view often gets measured incorrectly as part of the septum. And then we tend to use the short axis quite a bit for proper left ventricular wall thickness assessment. So this very yellow line right here is the proper septal measurement. This gold dimension right here incorporates some of the crista interventricularis here. But when you're doing all of this, you don't want to lose sight of the fact that the inferior septum can be the area of hypertrophy, or the anterior wall can be the area of hypertrophy. And those areas are a little bit silent on echocardiography, so we have to have a really pay attention to those areas. We don't see those very well except in the short axis view. And sometimes when image quality is suboptimal, there's areas that drop out in these regions. The other thing that can help us identify what is pathologic LV hypertrophy from physiologic LV hypertrophy is diastolic function and strain. So in athletes who have physiologic remodeling, their strain is often normal to supranormal. In this case, the E prime velocity is 25 centimeters per second. That's partly because they're a young individual, but also because their heart is adapted to extreme exercise. For individuals who do have a little bit of left ventricular hypertrophy as a result of physiologic remodeling, this may be lower, but it's rarely in the region that might be mistaken for sort of a restrictive cardiomyopathy. It's also important to note that patients with hypertrophic cardiomyopathy can have normal E prime velocities and they can have normal diastology. The other thing that helps differentiate the athlete's heart from hypertrophic cardiomyopathy is strain. And strain in athletes is usually pretty normal, with normal range somewhere between -15 and -18 or 19%. And for global longitudinal strain, and abnormal global longitudinal strain for hypertrophic cardiomyopathy, particularly with abnormal strain in the area of the septum or areas of hypertrophy. And finally, I want to mention that apical variant hypertrophic cardiomyopathy can be difficult to pick up on echocardiography unless there's a high index of suspicion. And this can be really identified using echo contrast or using cardiac MRI. But let's not forget about the tool that's probably easier at our disposal, and that is the EKG. I actually believe the EKG is a more sensitive test for apical hypertrophic cardiomyopathy than echocardiography, because these deep T wave inversions are classic and almost pathognomonic for this condition, where you have the deep T wave inversions that progress out here into the lateral precordial leads, sometimes also referred to as the apical leads. So if I see this EKG and I see that they have a normal echo, I won't believe the echo, and I'll go back and look at this again. Sometimes these abnormalities are due to apically displaced papillary muscle without hypertrophy in that area, but that's important to know about as well. The other gray zone that can occur, as we mentioned just briefly with the Tour de France athletes, is the gray zone between dilated cardiomyopathy and athlete's heart. Endurance athletes commonly have that LV dilation, and they can have ejection fractions in the 45 to 55% range, which can mimic the dilated cardiomyopathy. And this is in part because it's stroke volume, not ejection fraction, that is physiologically regulated. So that if you have a dilated heart, it takes a lower percentage of that blood being pumped forward to maintain the same stroke volume. Your ejection fraction at rest will be lower as a calculated value. Some tips in evaluating or considering the diagnosis of dilated cardiomyopathy. One is that we almost always will see four-chamber dilation. If you're doing enough exercise to dilate your left ventricle, you're doing enough exercise to dilate the other chambers, which are also a little more compliant than the left ventricle in general. We will commonly see normal diastolic function and normal strain in these individuals. And if in doubt, if there's any additional concern about whether this is a pathologic state or if it's a athlete's heart, we can consider a cardiopulmonary exercise test or even a treadmill echocardiogram. We can put them on a treadmill, make them exercise, and see what happens to their ejection fraction. Patients with a cardiomyopathic state will have a reduced ability to augment contractile function, while those individuals with athlete's heart will augment their contractile function robustly, such that their ejection fraction could increase a minimum of 15 percentage points with exercise. This is a case of an individual who had a dilated heart, dilated LV. He's a collegiate swimmer, left ventricle 6.4 centimeters, ejection fraction of 45%. He went on to have a cardiac MRI performed, showed no LGE, and a cardiopulmonary exercise test that showed a peak VO2 of 125% predicted. So all of which is reassuring for the idea that this might just be athlete's heart. The other sort of gray zone conundrum that can arise is that between arrhythmogenic right ventricular cardiomyopathy and athlete's heart. Usually right ventricular enlargement occurs along with left ventricular enlargement. Sometimes because RV is a little more compliant than LV, sometimes we can get RV enlargement that precedes LV enlargement. And there's some data from the MESA study using cardiac MRIs that it really only takes a moderate degree of exercise to create some RV enlargement. If you're looking at the heart and the RV is greater than the LV in size, then we should be considering other types of situations such as shunting or AOVC, and that would be an indication that additional testing might be needed. Again, similar to the LV, the resting right ventricular ejection fraction may calculate a little bit low, but there shouldn't be any regional wall motion changes. That's one of the clear classic findings or pathognomonic findings of rhythmogenic right ventricular cardiomyopathy. And we started to use RV strain in our laboratory, but it has not been well defined in athletes to date. The last sort of gray zone conundrum that can arise is that between left ventricular non-compaction and athlete's heart. So hypertrabeculation is common in athletes and is thought to be a benign component of exercise-induced cardiac remodeling. Just as the hypertrophy occurs within the myocardium, we can get some hypertrophy of the trabeculated segments as well. And anything that dilates the heart, be it exercise or be it pregnancy, makes these trabeculations more visible to the eye. So when we rely solely on the left ventricular non-compaction ratio criteria, that is the ratio of non-compacted to compacted myocardium, this can easily lead to the overdiagnosis of left ventricular non-compaction in athletes. And so we have to be careful about this diagnosis. And it's not one that I will give to an individual if they have normal ejection fraction. This is an individual, both the echocardiogram and the cardiac MRI here, showing some excess trabeculations. And in this case, the ejection fraction was 40% by echo and 48% by cardiac MRI. But the no LGE above normal exercise capacity. It's possible that this is simply exercise-induced athlete heart, but we remain open to the possibility that there may be more to that. And finally, although this is not in the gray zone, I think because coronary anomalies are one of the most common causes of sudden cardiac death, I think it's important to remind people that when we're looking and evaluating athletes, it's important to also take a look at their coronary anatomy and make sure that the coronary ostium are in the right location. Coronary anomalies, as I mentioned, was one of the more common causes of sudden cardiac death, and in particular, the coronary arteries that are interarterial and course between the pulmonary artery and the aorta are the ones that can lead into trouble. Most of these also have an intramural component, that is, they lie within the wall of the aorta, and they can have an acute takeoff with intermittent compression that can lead to ischemia and then can lead to arrhythmia such as VT and VF. These may cause chest pain, but they may also be exertionally silent. They're silent on EKG, but they can be detectable by echocardiogram. So if we are doing echoes in athletes, we should take that opportunity to look and see if they have any anomalous coronaries. We do that by looking at the short axis of the aortic valve and looking for the takeoff of the right coronary artery, which usually comes in about this location. And the left coronary artery usually comes in around over here. But in this case, you can see it's coursing between the pulmonary artery and the aorta, and it's coming off from the right sinus rather than the left sinus. I'll note that this takes a little bit of expertise in trying to find these coronary arteries. The pediatric group has pediatric sonographers have been routinely trained to do this. The adult sonographers may need a little bit reminder. It's always good as well to put color flow down the coronary to look for the diastolic flow component. And that is a way to sort of confirm that it is indeed a coronary vessel rather than an aortic dropout. So in conclusion, echocardiography plays a critical role in the evaluation of symptomatic athletes and for screening for the risk of sudden death in this population. Exercise-induced cardiac remodeling leads to changes in cardiac structure and function that can mimic disease. This leads to gray zones with hypertrophic, dilated, arrhythmogenic, and left ventricular non-compaction. When these gray zones arise, from an echo standpoint, we rely heavily on diastolic function, longitudinal strain. Exercise echocardiography can also be useful. But we also put it in, echo is one component. We also put it in into the picture of what their exercise capacity is, what their symptoms they have, what their EKG looks like, and then perhaps also things like cardiac MRI or PAT monitoring for rhythm monitoring, et cetera. And then a proper understanding of exercise-induced cardiac remodeling and the physiology that occurs in that setting is essential to echo interpretation in athletes, and really trying to understand who the individual before you, what type of exercise they do, how intense is it, how long have they been doing it, and is that exercise exposure enough or capable of causing the changes that you're seeing on the echocardiography in front of you. Thank you very much for your attention, and I'll be available to answer any questions later. Thank you.